little conversation with our panelists. This has all been so inspiring, and it's fantastic to be here and hear about all that's happening with Chat for Impact. We heard from Debbie earlier a lot about Mom Connect and Mom Connect Africa. We are about to hear from Anurav and Andy about their work after lunch. But I will ask you each to just give a quick overview of your work so we've got some context for the panel. And then what we'll be able to do is do a deeper dive into some of this beyond what you'll hear in their presentations later.
Thank you, Kirsten. I lead a product at Noura Health, which is a non-profit organization that works with public healthcare systems, facilities, clinics in India and Bangladesh. And we train family members of patients on post-discharge care. And as part of that intervention, we have our digital solutions, including chat, that I'll be talking about in this panel and post-lunch.
Great, thanks. Andy?
Hi, Andy Patterson from the World Health Organization. I'm privileged to lead a small team called Digital Channels, and our job is to get more health messages to more people through those channels so that they can make better health decisions and hopefully live healthier lives. I work almost exclusively with the tech industry, and over the last 3 years, we've had at least 150 projects with large tech and small tech around the world, including fantastic collaboration with PreKelt, Turn, and WhatsApp, amongst others.
Great, thanks. So we'll go ahead and start with you, Debbie. I loved what you said during your presentation about considering this an engagement service and that you've got all these different channels that you're using. You talked in your presentation about some of the replicability issues of IVR and SMS and what really kind of led you into using WhatsApp. Then you kind of ended by talking about Mom Connect Africa, which is super exciting. What do you anticipate might some of the challenges be with being able to replicate using the WhatsApp channel now to other countries in Africa? And are they similar to, or how are they different from some of the IVR and SMS challenges?
Thanks. I think, as with most technical solutions, the problems are not the tech. WhatsApp has and other other IP messaging platforms have solved some of those replicability issues from a technical perspective. But ultimately, this is still about getting buy-in from governments to extend their health system using technology. It's about ensuring that NGOs, governments, and for-profit organizations are working together towards the same goal of healthy populations. It's about ensuring that there is data integration so that there are not a bunch of different systems running around doing the same thing, and they can speak to each other. And those continue to happen. And I think it just means that we have to be thinking beyond the technology itself. The technology is actually the easy part, to be honest. If you really want to have an impact in the world, I do believe that technology plays an important part, but it's not going to do it by itself. And it's all about how you actually are working through partnerships to be able to take these sorts of programs to scale.
Great, thanks, Debbie. Well, along those lines, Andy, when you're thinking about the health chat that so successfully launched during COVID-19 and massively scaled in a short amount of time, Mom Connect is definitely trying to reach some of the hardest to reach populations who also tend to be illiterate. And when you're trying to reach some of the most vulnerable and hard to reach populations who often are illiterate or have different degrees of illiteracy, there's been research that shows that people who are more illiterate are more susceptible to misinformation. So how do you reach those people, and how do you make sure that they're getting the trusted information that they really need?
It's a good question. Actually, I'm probably going to dance around it rather than answer it directly. I tend to do that. Apologies for that. I think two ways of looking at this. First of all, WHO's role, I think, is to serve the vulnerable and to reach populations who are not being served because either their local ministries of health are not able to or not willing to give them that kind of support. So to give you some examples of the health chatbot, when we launched the Arabic-speaking version of our chatbot, 50% of our users in the first 3 months were for the country of Yemen. And Yemen, as you know, has got a completely depleted and destroyed health service. In fact, WHO, and I believe with support from UNICEF, is the only health service in Yemen at the moment. So those kinds of populations, I think we use technology to reach them over large areas, just to reach them with technology rather than being there present. Another good example is how we reach Kurdish-speaking populations. The Kurdish-speaking populations live across numerous countries, but are not very well served by the countries in which they live in. They're seen as minorities, and only NGOs are really serving them. So we partnered with an NGO to actually translate our content into Kurdish, get it cleared, and then push it out. Again, knowing and hearing back from the community that this is the only information that they're getting in their own language, literally in the palm of their hands. And just to go back onto what Debbie said, I think nothing that we do can happen without partners. We may have the credible source of health information in the world, but we have no platform. We have no real voice. We have no clever way of getting our scientific message across without really working with partners who have got creativity and technology and reach and real impact for people to actually hear those messages. So I've not answered your question, but I've danced around a little bit.
No, but I'm going to follow up and ask you a targeted follow-up question. So those are great examples, and exciting that you were able to fill kind of a vacuum where there wasn't information in Yemen and in the Kurdish language example. But what do you do in places that have prolific social media and memes and misinformation that's out there? How do you get the WHO information kind of above all of that noise?
Yeah, that's a good question. So actually, our work is on 3 different pillars. Our first pillar is raising good content, whether that's WHO or our partners or the Ministry of Health. So that's one of our first thing is, let's get that out. And the reason that's important in the conversation of misinformation is misinformation thrives in a vacuum. Yeah. So if there's not credible source of information out there, misinformation is going to start and rumors are going to start. The second is we fight misinformation itself, and the third pillar is gaining user insights. The second pillar, we will fight individual posts, individual claims, but a lot of our work happens behind the scenes. It's extremely unglamorous. Every single week since January 2020, my team have been on calls with YouTube, Meta, which includes, of course, Instagram, Facebook, and WhatsApp, Kaishu, which is a large Chinese company with properties around the world, Viber, and dozens of others, every single week, week in, week out. And we work with their policy, security, and safety teams to debunk myths so that they can use their technologies to remove it and their engineers to remove this content. The other thing we do is working with the tech companies, we paint the problem definition. I think WHO has been traditionally quite poor at finding solutions. But what we are good is finding the problem definition. So we will actually, I'll go up to we have a tech task force, which is 60 plus companies every month we talk to. And we say, this is top of mind for WHO at the moment. This is the problem we're trying to solve. And then I encourage them and ask them to find solutions to those problems. And we've seen that time and time again where just by planting a seed and watering it a little bit, these incredibly creative people who work in tech go off and find ways to reduce the spread of misinformation. Ben is here from WhatsApp, so he's a better place to talk about it, but WhatsApp is a perfect example of how they put technology and features into their product which stop you spreading photos to large groups of people in one click. You have to spend effort, and fortunately humans are quite lazy, so they send it to 1 or 2 people rather than their entire address book. So it's these encouragement of these companies to find creative solutions which makes their platform, let's say, healthier on both sides of the spectrum of health.
Great, thanks, Andy. So we've heard in these couple of examples that there's more than one channel that needs to be used. Nora Health is more than just a chatbot. There's multiple modalities, both technology and in person, that you use to reach caregivers and patients. Can you tell us a little bit about those and why it's important and how they work together?
So as I was explaining before that, our first touch point with the patient and the family happens at the clinic and the facility, right? That's the point in their life when they go through that health shock, whether that is a surgery or whether it's a happy event in the case of a new mother. and they are in that mind space of really learning, and that's when we first capture them. Debbie was talking about how it's not just it's not about technology all the time. We offer them the in-person training sessions there and then, and that becomes then a conduit for us to onboard them onto the digital platform. Within the digital platform, again, we are not just focusing on chat as a platform. In India, over the past several years, the WhatsApp and technology penetration has really increased. But still, you see pockets of cities and communities where people don't have smartphones still, and we always ask ourselves that, how are we reaching out to those communities? And that's where something as simple as IVR is still, right? Like, still makes a lot of sense. Something as simple as, training on the phone. It is more resource intensive for sure, but that's where tech can really help kind of triage, patients into different risk buckets. There we talk about, risk stratification, and then kind of, tech can help us, decide the dosing of those different interventions. Who needs that personalized, extra training through a human? So those are the different channels that we, have.
Great.
Yeah.
All right, thanks. Debbie, one of the things that I'm really intrigued about, I think, we've seen a lot of examples throughout the morning of different Chat for Impact that were very citizen-led and kind of outside, extra-governmental kinds of things. I know that one of the ways in which Mom Connect South Africa scaled was through a partnership with the South African government. And it didn't start off with a partnership with the South African government, but it got there. So I'd love for you to tell us a little bit about the journey of that partnership and what you see as the real power in partnering with government.
Yeah, so as you said, we started working in maternal health messaging as a part of the Mama program in 2011. And at the time, we're really trying to prove a case for why it was important that we would use technology to deliver stage-based messaging. And we were lucky enough to be able to experiment a lot, do a lot of things badly, do a lot of things well, so that we learned really, how do you take this to scale, which channels are most effective, which channels are used for which things, and then could put together a holistic program around maternal health messaging. We had been doing this completely outside of the health system and had been doing it really much more tech-led, I would say. And then the National Department of Health put out a strategy around integration of digital health records. And they recognized the importance of maternal health messaging. And they called together a group of organizations and said, you're all working in the maternal health messaging space. We have a problem we want to solve. We need to have up-to-date information about who is registering their pregnancy where, and we think mobile can help. What have you got? What can we reuse? How can we partner with you? And how can we make this move quickly? And I think that was just like an absolutely pivotal moment, and the leadership from the National Department of Health saying, we recognize the opportunity. We're also not trying to reinvent any wheels. We want to work with those people who are doing this and accelerate what we're doing. And so through really collaborative effort, what was started off as a pregnancy registry really became Mom Connect, and it's become something that not only empowers government with data that they would never have had access to in real time, but also empowers the mothers themselves in their health. And I think without that, we would never have reached the scale that we have. We would never have been able to reach the most vulnerable, because the most vulnerable are really the ones who we're going to have the biggest impact on. And they're the least likely to have been attracted by advertising or to be reached through other means, but they can be reached through community outreach. They can be reached at the clinics. And so we definitely would never have been able to reach that kind of scale. But at the same time, I do think we are helping mothers to live healthier lives, but they cannot be the only people making a change in the system. We can't just keep sending them back to a broken system. And so what I think was really kind of brave of the National Department of Health is to say, tell us what is wrong, and we will try and fix it. And so that feedback loop that's created, where you're not just putting all of the burden on the mother, but also taking that feedback to change the system itself. I think if we don't have more of those kinds of approaches, we're just going to be fighting a losing battle. And I think that really is what our partnership with the National Department of Health has been about.
Great, thanks, Debbie. It's multi-layered, both in the actual partnership, but it sounds like in the results as well. You mentioned data in there too, and that the Department of Health was able to obtain a lot of data that it didn't have previously. And I understand this work is work, especially the work that WHO did during COVID-19 in partnership with PRACALT was rapid iteration. You had to get that stuff out there. You didn't have time to do long academic research studies. So I'll ask this question with slightly different lens with Andy and Anubhav. What data do you have on the users and on the impact of the service, and how do you use that data to just rapidly inform what you're doing and make iterations and make changes quickly? So Andy?
Actually, we do it very badly, to be honest.
Okay.
During COVID, our strategy, and it still is in my team, is to launch quickly and iterate often. Let's find the minimum viable product and get it out there, and then constantly improve. My team, we have a motto: 80% today is better than 100% tomorrow.
Great.
And we just want to get out there and do something for somebody rather than try to do one thing for everybody, which just doesn't work. If anybody been in this kind of area of public health, when you try and do a product for everybody, it never works, right? It becomes so diluted. So this, during COVID, we were launching product after product with this mentality. All of this based on a constantly evolving science. I think this is the first time where we've gone out on a new disease with such a loud communication strategy and risk communication strategy. So our focus has been mostly on keeping on top of the science, keeping on top of the translation process into the 20-odd languages we have on our chatbots, which is a nightmare, and not looking so much at the data, because we were looking at broad brush, get out there as quickly as possible into the palms of their hands, into people's digital journeys. What we do need to do is to take a deep breath and look back and really investigate how this came about. I would love to do case studies, and this is a call for action for people in academia who may be watching this. How can we work with you to get case studies on some of our products, to get peer-reviewed papers published, so that the public health ecosystem can benefit of what we've done? In the future, what we're doing is we're actually hiring a strategic editor and writer to actually do this in line as we launch products. So we're going to be doing proper, let's call them digital health case reviews in real time. So we'll actually have surveys before, we'll select a cohort of people, different cohorts will get different messages, we'll evaluate, and then do surveys afterwards to see if there's behavior change. Because WHO has big numbers when it comes to the chatbot. So big that half of my colleagues don't actually believe Andy's telling the truth, right? Half the time they're like, really? That's not possible. But actually, so what, right? Does it matter if there's no change in behavior, right? I use my case of my friend in London, David. He's an avid smoker, an enthusiastic smoker, I would say. It doesn't matter how many times he understands that it's bad for his health. He's not going to get healthier until he stops smoking. So I think the big challenge that we've got ahead is the so what. How do we measure that impact of really seeing it? And I'm very envious of the Mums Connect. We met some beautiful mums and some beautiful babies yesterday. And that really, grounded me to this is how you get information back from people to say whether your service is useful or not. So never mind the data, but the human side as well is important.
Yeah, I really agree with that. And also I just want to kind of pluck out some important aspects of what I just heard from you, and then we'll go to your answer on above. So I heard you saying three things, really, is that you did the scrappy, let's just get it out there, like we got to get this out there, let's boom, do it. and you're working on this academic look back and the peer-reviewed papers and all of that, and you're putting in place new procedures and policies for moving forward. So I just feel like kind of saying we're doing all these things and we're not waiting for the academic research before we do those other things, but we're doing all three of them.
Yeah, and I would just like to add to that everything we did for COVID was a massive accelerator for us.
Yeah, totally.
You know, and my organization is not one that's generally known as moving quickly and swiftly.
That's true.
So I would sometimes ask for permission, and a few days later they would come back with questions, and I would just say, sorry, the service is
It already
launched.
happened.
It's already gone, you know, the launch is gone. So it made lots of people very nervous. But my point is, everything we've learned through COVID, the reason why it's important to document is actually we now have to pivot.
Yeah.
Everything we've done on COVID to tackle some of the biggest killers on the planet, non-communicable diseases, maternal baby health, mental health, climate change coming up next year is a big year for climate change and health. How do we pivot, apply our learnings to all of these really other health
Great.
topics?
Thanks. So Anubhav, same question for you. How do you use kind of what you're learning in the moment, metrics and data, to iterate? But I know you're also looking at scaling now to Indonesia and Nepal. How are you using that information that you're getting kind of in the moment to inform that as well as your current program?
Yeah. On the data piece, I'm suddenly slightly proud because we are not doing as well as the WHO, on the content piece, but definitely on the data piece, we are doing a few things. I'll tell you why it is challenging, to really track a user journey in the digital world. The digital journeys are kind of fickle and broken, right? When you compare them with the physical world, like in our sessions in the hospitals, we are able to quickly gauge whether the user is distracted, what are they doing, with their phones, are they signing up or not. In the digital world, when we send a message out, whether that is voice or text, it's difficult to understand what are they really, whether they are listening to the message, are they reading one message at a time, or whether they are, glancing through 10 messages at the same time. So yes, science on this is evolving. You can still have control and intervention arms, which we are dividing our cohort in. But there are some easy directional metrics that one can also look at. For example, message recall. Through qualitative interviews, are people recalling some of the messages that you're sending them? Through message recall, the impact on knowledge retention. And then some simple behaviors such as, if you're nudging them towards going to ANC visits, are they really doing that, right? Are they engaging with, simple buttons on WhatsApp? So some of these can give you some early indicators whether people are engaging with your solution or not. But the ultimate test is always kind of, looking at more rigorous research, which takes time.
Great. It does, as well as those visual cues that you're seeing when in person. Go ahead, Debbie.
I think this is really, we're an organization that works in health and in tech. And this is a constant struggle for us because we're working in two very opposite worlds. On the tech side, it's all about A/B testing, move fast and break stuff, get stuff out there, then we'll make it better. The technology you deploy today is not the technology that you're going to deploy tomorrow. It's incredibly fast-paced. Then you take the traditional health space, which is...
The WHO.
Not Andy's team,
Not
that's
Andy's
for sure.
team, no.
And that's, we can't do anything until we've done a 5-year randomized controlled trial, and then we can maybe start talking about whether or not it's effective. And the clash of these two worlds is very challenging to manage. And so, I don't think we've got it right yet. I think it's going to take a lot more people in the tech world understanding better the value of the rigor that comes with health, and people in the health world understanding better how to evaluate things that are changing quickly, because you can't stop the evolution of the tech so that you can do a randomized control trial, because then it's not going to be useful to anybody. And so that idea of working between these two disciplines or across these two disciplines and the transdisciplinarity that is needed between the two, I think is going to be critical to see if we can really bring the two worlds together in a way that satisfies both sides.
Yeah, well, I think one of the silver linings of the pandemic was it kind of forced some of that, right?
People learned they can move a lot faster.
And if you throw data protection, data privacy into this,
Right.
it makes a lot of people very nervous,
Yeah.
right?
Yeah.
Because there is a fine line between freedom of speech and misinformation, like there is of sharing data for public good and your own data privacy. So,
And in health, you're talking about health data.
exactly,
Yeah.
and it's very, it's a very touchy subject.
Yeah,
So.
yeah. Thank you so much, and thank you to all three of you. We could sit and talk about this for hours, so thanks.
Thank you very much.
Thanks.